I think the chair was put there to make the short ones feel a little bit more at home. Thank you so much to the Policy Forum for this invitation, and to Patty and Otis for really moving this workshop forward. Patty was teasing me earlier that she keeps inviting me to these IOM workshops, and I keep accepting. And I was reflecting on that, and in part I really am challenged by listening to my colleagues, but perhaps even more so, I love listening to the voice of our patients, our family members. That last session was just incredibly emotional, but through the whole day, that is what challenges us and motivates us as we go back to our work. So the issues that I was asked to address is looking at healthcare for adult survivors, why it's important. A couple of terms you've heard today, risk-based healthcare and risk-stratified models of care. What does that really mean? Talk a little bit about education empowerment, who needs it, and then interpret where we might see with changes with our healthcare system in the U.S. I like starting with a patient. This is Terry. Terry was diagnosed at the age of 6 in 1960 with a Wilms tumor. Her pathologist was Sidney Farber. In fact, her treated up in Boston, Lisa. Her chemotherapy was administered by Audrey Evans. She received actinomycin, and her radiotherapy, as shown on this next page, was administered by Dan DiAngio, three real pioneers in this effort of pediatric cancer. Several people have mentioned so far the Childhood Cancer Survivor Study. It's a large study that's been ongoing since 1994, involving 26 institutions, but I simply want to show you where people live, and this is well penetrated across our country. This is the original cohort. We just recently completed the expansion cohort, so we now have about 24,000 patients that are enrolled in this study. Smita showed this study, this slide earlier, showing that the farther out people are from their cancer diagnosis, the more likely they are to have a chronic health condition, including often serious chronic health conditions. And what I really want to point out is many of these patients are in their 30s, 40s, 50s as we look at this data. We had the opportunity recently to work with our colleagues at the NCI and SEER, where we took the data from the Childhood Cancer Survivor Study and looked at it, how representative it was through our SEER, and then took and projected estimates nationwide of what the burden of morbidity that we have now existing in our country is. And you can see here, grade 3 or 4 are more serious conditions, including life-threatening conditions, than grade 1 and 2, and then the green is no condition. And as you look at the serious conditions, really focus on those patients that are in their 30s and 40s. A third of the patients in their 30s, half of the patients in their 40s having a serious health condition. We looked at this further in the Childhood Cancer Survivor Study recently, Greg Armstrong leading this analysis, where we were interested in people having multiple health conditions. And so the first line you see is the first condition, and these are serious conditions: heart attacks, second cancers, things that really affect their long-term life expectancy. And then you see as they get into their 30s, 40s, and 50s, they start having their second serious condition or their third serious condition. Or if instead we looked at having a new serious condition where you previously didn't have one, and you think about what happens when you get into your 30s, 40s, and 50s, again, we see the people that never had a condition, a serious condition, starting to have them in their 30s and 40s. So the message here is that we see these things unfold over time. Now, the good message is that there's many things that we can do to prevent or to change that, and that was really the key message that came out of the two Institute of Medicine reports on survivorship in 2003 and 2005. And through that effort, during and after, that was articulated this whole concept of risk-based healthcare for cancer survivors. Early on, that's monitoring for recurrence, but later on, it's monitoring for second or third cancers or monitoring for other late effects with an eye towards early diagnosis and intervention. As you've heard through the thread today, prevention is very, very important. Tobacco cessation, tobacco avoidance, physical activity, calcium intake, et cetera, and then counseling and targeted education. So a major effort that was led by Melissa Hudson and Wendy Landier and others through the Children's Oncology Group started the Children's Oncology Group guidelines for screening this population. Here's version 4 in 2013. The original version launched in 2003. And since that time, since the first version was out, other countries have also started to work in this area. And so we actually have developed a group that's international to harmonize guidelines across different healthcare systems and to mobilize and synergize our efforts. So how are we doing? Let's think about that. I've seen some of the slides, and this really builds upon some of the things that Lisa was emphasizing earlier. As we have patients that are going into their 20s, 30s, and 40s, and they're starting to experience these chronic health conditions that I mentioned earlier, are they being seen simply at a cancer center, whether or not it's in a long-term follow-up program or not? This is data that Paul Nathan and our group published a few years ago, and you see as they're getting into their adult years, the likelihood of being seen at a cancer center is actually fairly low. So what about some of the conditions that show that morbidity or lead to early premature mortality? This is one of the major things that we think about, are women that were treated with chest radiation for their childhood cancer. This is data that we published last year where we looked at that and compared women treated like that to women that have a BRCA1 or a BRCA gene mutation or the general population, and simply stated our women that had Hodgkin lymphoma were treated with chest radiation, had a risk that actually exceeded women with the BRCA1 gene mutation and well above what we see in the general population. 1 out of 3 women treated like this had breast cancer by the time that they were 50 years of age, where in the general population it's about 4 out of 100. And that led, that and other studies led to the Children's Oncology Group guidelines and indeed that International Guideline Harmonization Group. And if you go to the website, what you will see is a recommendation for an annual mammogram and a breast MRI starting 25 years of age or 8 years after the radiation therapy, whichever occurs later. And so we thought, well, how are women doing? We surveyed women in the US and Canada to look at the proportion that had at least 1 mammogram in the last 2 years. We would like to see at age 26, they're already up to 100%. And instead what we see is that there's a slow uptake of their screening, and it's really not that different than 2 populations that are at average risk for breast cancer. Childhood cancer survivors who did not have chest radiation and the sisters of childhood cancer survivors. And in fact, if we even looked at having a regular screening practice, 2 mammograms in the last 4 years, you see essentially no difference between our high-risk group that I was telling you 1 out of 3 by age 50 have breast cancer versus our average risk groups where we see 4 out of 100. So it was really brought home by a nice study that's been ongoing through St. Jude called the St. Jude Lifetime Cohort led by Melissa Hudson and Les Robinson, where they're bringing patients back that they're in their adult years and they're finding out what problems they have as they come into evaluation, but then they're doing full screening based upon the COG guidelines. And this is impressive. This just shows 6 examples of what they found prior to and then after their evaluation. So these patients are often running around with undiagnosed and often serious problems that have not been yet detected or symptomatic. So this leads us to the question, can we educate and empower adult survivors of childhood cancer from a central virtual site? These patients have moved away. Can we take and coordinate our resources or infrastructure and thereby connect them with their primary care physician? This is a really nice study that Melissa Hudson recently reported on called the ECHO study, conducted through Childhood Cancer Survivor Study, that simply stated they randomized patients either to getting a cancer treatment summary and a survivorship care plan, or that plus a couple of calls with an advanced practice nurse, and then followed up with some reminders. And then looked to see whether or not they had an echocardiogram 12 months later. These are patients that are at high risk for having a cardiomyopathy who had not previously been getting their screening, and simply show that the intervention, they went from 22% in the control group to 52%, completing the echocardiogram within 12 months in the intervention group. A similar study that we have ongoing is called the EMPOWER study. This is trying to show the information that's necessary to act upon for screening in our women that have had chest radiation, again through the CCSS, where we're providing information to the women to take to their primary care physician to get their screening. We have completed enrollment. We've completed 12-month measurements and should be analyzing that data in the next few months. So let me go back to that slide I showed earlier, that disconnect that we have from the cancer center. And you think, well, what about the primary care physician? Are they familiar with the type of problems that these patients are if they're not coming back to the cancer center, if they're not being seen in long-term follow-up programs? This is an elegant set of studies that Tara Henderson has led, where she surveyed multiple groups about their comfort level, their acceptability, their confidence level with taking care of childhood cancer survivors. So first of all, she started out asking general internists and family physicians, large populations, had you seen a childhood cancer survivor in the last 5 years? Note that 75, 80% had not seen a childhood cancer survivor in their practice in the last 5 years that they realized was a childhood cancer survivor. Many of these patients are floating around with it buried in their past medical history. And even for those that were seeing childhood cancer survivors, I'll remind you, this isn't a single entity. It's a very heterogeneous group. We have leukemia survivors, Hodgkin survivors treated with different exposures over different time periods with different risks. Were we communicating with them? 72% of the general internists had never received a treatment summary, ever. 48% of family physicians, and these were the ones that had been seeing patients. So then she asked a clinical vignette, and based upon common areas, a young woman with Hodgkin lymphoma, would they have breast cancer screening, cardiac screening, and thyroid screening based upon the COG guidelines. And you can see that for breast cancer screening, cardiac screening, it was below 25% for both groups. They were much better with thyroid screening, but all correct in all three of the areas was very rare. But if you look at pediatric oncologists, and Tara surveyed pediatric oncologists across the country, you'll actually see that what's happened in our country is this population is being transitioned to long-term follow-up fairly early, and our pediatric oncologists are not often aware of the specifics of what the risks are or what the recommendations might be. So I want to be very careful and not beating up too much on our primary care physicians in the community, myself being a family physician by training. So do we simply build programs at the cancer center for, say, 388,000 adult survivors of childhood cancer, the number that we have estimated in our country as of 2001? Well, our colleagues in the UK, led by Hamish Wallace, came up with a risk stratified approach a few years ago, where they looked at, and I apologize for the smaller font, I tried to blow that up, but if you look at risk level, they stratified them into three groups. And the low risk group are patients that had surgery only or low risk chemotherapy. 2 is an intermediate group, and then the level 3 were those that had radiotherapy except for low dose cranial radiation and what they considered to be megotherapy. And then they looked at how they might be followed up. The low risk group, not over medicalizing them, getting back out to the British GP, followed perhaps by telephone or by post. The intermediate followed by a nurse or primary care physician, and then transitioned back. And then the high risk patients followed up in these specialized clinics. And this really makes sense because now you're using your resources where they're most needed. And so they tested that out within the population in Edinburgh. And so they looked at the patients by level and looked at what type of conditions that they had after they were separated out into these three groups. And if you look at the percent of their population that fell into these three levels, about 14% in level 1, and then 40% and 40% in level 2 and 3. And what you see is that their stratification approach actually did pretty good. It separated out those patients that really were having a high risk with what we knew from just simple treatment exposures, a very crude way of looking at it. So we and others have articulated thinking through what this is. And I'm not going to go into the details. It'll be in the handouts for those that are interested. But there's multiple handoffs. And I want to be very, very careful is that when we say we transition them off, that seems like it's hi, bye, hope you enjoyed your ride. We'll see you back if you ever have a problem. In fact, my first survivors that I used to see in Dallas 20 years ago, they would say what was common practice is that they would be told, we'll see you back in 20 years, which meant if you ever had a problem. And this is not a handoff that's one time. This is communication that should be going on based upon the risk of the individual. So this is showing some of the low risk and the moderate and high risk patients so that, again, we can allocate our resources to those patients that most need them, especially in an economically constrained environment. And so what's an example of those patients in the high risk? Are patients that have had a hematopoietic cell transplant. They've had therapy prior to being considered for their transplant, then they have their preconditioning therapy, which might have included total body irradiation. They might have had problems during their post-transplant, including graft versus host. And this is just a litany of the different types of problems that we might see in this population. Multiple organs, multiple morbidities that are unfamiliar a lot of times to clinicians practicing outside of the cancer center. I like a couple of terms that our Canadians use. Knowledge translation and knowledge transfer. How do we take complicated, sophisticated information, make it plain and simple? I'm a simple person. I like things that are simple. And then how do we transfer it to whoever needs that information? So when we look at what our primary care physicians keep telling us survey after survey, study after study is, I like the cancer treatment summary, survivorship care plan, keep it short. I don't need 17 pages. I will not read 17 pages. And I want to have the ability to communicate with you. When I see something that comes up on one of the patients, I want to know, is this something I need to be worried about or not? What's our survivor need? I want a survivorship care plan that's in plain English to let me know what we need to pay attention to. And I want to have communication between all parties. So our cancer treatment summary survivorship care plan is actually very simple. My goal is all of our patients, even our patients with 3 primaries, is to be on one page and not using super small fonts. And our nurses are very good at being able to do that. So it provides the key information of their cancer diagnoses, their treatment information with key components of that, their potential late effects, and what the screening recommendations are, and where they're based from the COG guidelines, and contact information for getting in touch with our group. So we've talked a lot about follow-up care of our cancer survivors. I've mentioned one of the expensive tests, of breast MRI. Do our patients have the ability to get this? Do they have the access? Do they have the insurance? We know from a number of studies through the Childhood Cancer Survivors study that childhood cancer survivors are more likely to have lower skill jobs than their siblings in all groups except in our osteosarcoma population. They're often underinsured or uninsured, and this just shows you some very crude. And this, remember, this is almost the best of the best. These were patients we could find with very, very intensive methods back in the 1990s, early 2000s. So it's underrepresenting patients that don't have insurance or may not have the ability to participate in a large cohort study. We know that uninsured survivors are much less likely to have their follow-up care and follow up the recommended screening, and survivors often have very low expectations of their insurance coverage. They're happy just to have some type of coverage and frequently have out-of-pocket costs exceeding $2,000. One of my patients that's in her mid-50s is a Hodgkin lymphoma survivor that's had 3 cancers and a heart valve replacement, used to work for Standard & Poor's. She's great with numbers. She took 1 year and calculated to the minute how much time she spent on her health care is 10% of her time, including sleeping time. 10% of her time was devoted to her health care. Not just talking about cost in dollars, but cost in time. So what will the Affordable Care Act do? Well, first, what our hope is that it'll increase the number of survivors that have at least some level of coverage. We no longer have that C word attached as a pre-existing problem. There's an encouragement in the use of e-health and communication, but there's many challenges. Otis and I have had a number of conversations recently with the ACS in terms of thinking about screening for cancer in the general population. We have large studies to be able to look at this where we can develop systematic reviews and evidence-based reports, but the population numbers that we have for this group are much smaller. And will we be able to have A or B level evidence? The U.S. Preventive Service Task Force has not issued any types of recommendations on this population, nor do they intend to. And similar groups, do we have the ability to show the level of evidence that our insurance companies will cover it? And indeed, even if we do, what will be the out-of-pocket costs? And do we have reimbursement for management of patients that have complex medical problems? And our challenge, again, is thinking outside of the box. We've heard the term medical home a few times today. This is very different than the patient that has cystic fibrosis as a child, and now they're an adult. They go from a pediatric pulmonologist to an adult pulmonologist. The problem is essentially the same. And instead, what we have is a child that had cancer, that has problems for multi-organ problems that are totally different and distal from their cancer, that may not show up for 15 or 20 years, and we'll see a whole assortment of providers. So where do we need to go in the future? Certainly expanding upon the risk stratified approach and further study methods. I really love listening to Lisa's talk. She is bringing that type of rigor that's needed for our studies. Enhancing communication, it doesn't occur at one point in time. This is a lifetime. And study the utility of patient portals that allows us maybe a little bit easier way to communicate with patients, but I'm still unsold on that. And then to better understand the healthcare needs of our survivors. In this short time, I've not addressed many important areas. The psychosocial and rehabilitation needs that's very real that I see with our patients. We follow about 1,000 high-risk patients of childhood cancer in our center that are now in their adult years. Psychosocial support that they will need. There's spouse and partner support. The importance of health behaviors on their outcomes, managing comorbidities, and when will the next shoe drop? That sense of uncertainty that our patients deal with. So let me bring you back to Terry. I mentioned she was 6 when she was diagnosed with her Wilms. She was treated essentially with radiation from here to here. She had dactinomycin and her kidney taken out. Her risks we knew based upon our research are infertility, ovarian failure, renal dysfunction, second cancers, pulmonary disease, et cetera, and indeed she's had many of these problems. She is infertile. She has a single kidney that has multiple stones, has renal insufficiency. She has significant lung disease, has had bilateral aorta iliac disease requiring stents, including multiple stents. This is her treatment summary. But this is what I want to leave you with. These patients can live long, productive lives with the proper monitoring and follow-up care. And with that, I'll thank you for your attention.